who was honored with the Physician Health Promotion Award in 2019 for his dedication and leadership serving marginalized Nova Scotians. Since he began practicing medicine 40 years ago, Dr. Fraser has worked at the North End Community Health Centre, a community-based collaborative health center on Gottington Street. He has devoted his career to bringing crucial services and support to people who are stigmatized by the healthcare system. In addition, Dr. Fraser practices at the Pain Management Unit at the QE2, providing care to people suffering from the comorbidities of chronic pain and opioid use disorder. He enjoys mentoring medical learners in chronic pain, addiction, and harm reduction, and gives talks on these topics across Atlantic Canada. Thank you for joining us today, Dr. Fraser.
Thank you very much. It's great to be here. I appreciate the invitation to present again this lecture, and I'm happy to be here again. So I have no conflicts of interest to disclose. What I want to talk about today is in the first half, opioid use disorder, and in the second half, opioid prescribing for chronic pain. The two issues are closely related, and I think it's hard to talk about one without mentioning or having some discussion about the other. To begin, however, I want to talk a little bit about the so-called opioid crisis. This is an issue that has been prominent in the media and also prominent in medical literature. But there are really two crises, the crisis related to opioid use disorder and also the crisis related to chronic pain. And unfortunately, they're often confused and mixed up. The crisis with opioid use disorder is one of overdose deaths, which is primarily related to fentanyl, but also to heroin. With the chronic pain, however, the primary problem is overprescribing. And although there are issues with overdose deaths connected to chronic pain, that problem is really quite minimal, as we'll see later off in the talk, and doesn't really contribute to any significant degree to the overdose deaths that we're hearing about in the media. But unfortunately, when these two problems are linked, which they often are, both in the media and in the medical literature, then there's this sort of impression that the opioid prescribing for chronic pain is in fact contributing significantly to the overdose deaths that we're hearing about. But that just really isn't the case. The overdose deaths, as I mentioned, is related to fentanyl, illicit fentanyl, not pharmaceutically produced fentanyl. And unfortunately, when these two problems are linked in that way, then there's this response where some patients then do not get the opioids that they need for chronic pain and end up suffering. So opioid use disorder has significant global burden. This chart is designed to compare opioid use disorder, the prevalence and the disability, compared to three other significant problems that we are aware of. You can see there that, of course, alcohol use disorder has fairly significantly more prevalence than opioid use disorder, but very similar prevalence to HIV and motor vehicle accidents. And when you look at the column on the right, what's prominent there is that the disability globally related to opioid use disorder is significantly more than the other three, and in fact is about equal to all of them combined. And what are those disabilities or those harms? Well, of course, the major one is mortality, overdose mortality. The overall mortality rate with people with opioid use disorder is about 10 times that of a comparable population. But for those people that are using intravenously, that figure goes up to 14 times. There's a significant number, 18% of people with HIV, about half of people with opioid use disorder have hepatitis C, significant numbers have endocarditis. More than 40% have experienced a non-fatal overdose during their time with active opioid use disorder. And of course, not unexpectedly, the rate of crime is significantly more, approximately 6 times more than a comparable population. These are figures. This is a map from 2020. indicating there, you can see at the top, over 6,000 deaths related to opioid use disorder in 2020. And you can see by the shade of purple that there's significantly more out west, and as you go east, becomes less. And this is also indicated here by this graph. The dotted line is the Canadian average, and so BC is higher per 100,000 population, and as you go east, it becomes less. So Quebec and Atlantic Canada, much lower rates per 100,000 population. This was the first slide with a little bit of a misprint. It's not per 100,000. It's actually actual numbers of overdose deaths from 2016 to 2020. There was an increase and then a sort of stabilization in 2017 to 2019, and then a significant increase last year, which presumably relates to the other crisis that we're experiencing, the COVID crisis. If you add up those 5 years, you get about 21,000 deaths over the past 5 years, which compares to what we know now, about 28,000 with COVID. So a very significant number of overdose deaths, almost all related to fentanyl, as you can see here in this slide. So this is, again, deaths per 100,000 related to different opioids. The top line, the green line, is total overdose deaths. The blue line is prescribed opioids, and you can see that there is sort of a gradual increase up until about 2010 when things seemed to level off. In fact, there hasn't been a significant change since 2010. Interestingly, methadone, the orange line, sort of peaked in 2006 and has been steadily decreasing since that time. Heroin in the black line started to increase and has been increasing every year since 2010. But the real story here is the fentanyl, the red line, which took off in 2013 and had another increase in 2015. And you can see when you look at the green line at the top, that increase that started in 2013 and increased more to 2015 is all really related to fentanyl. So it's the combination of fentanyl and heroin that has driven this, but primarily fentanyl driven this huge increase in overdose mortality. So how do we do an assessment for opioid use disorder prior to treatment? Of course, the most important is to make a clear diagnosis using DSM-5 criteria. And the primary sort of focus with DSM-5 is that concept of continued use despite harm. So in spite of HIV, endocarditis, hepatitis C, of a previous overdose, in spite of impoverishment and homelessness, criminal incarceration, in spite of disrupted relationships, particularly around family, people continue to use. And that is sort of the hallmark of all addiction, but specifically also opioid use disorder. Then in addition, we want to define the risk behaviors, things like intravenous drug use, unsafe sexual practices, and others. Clearly, we want to know about other substance use. Most people who have an opioid use disorder have other substance use disorders, cocaine, crystal meth, alcohol. And then, of course, the associated comorbidities, bloodborne pathogen disorders, HIV, Hep C, cardiac, hepatic disorders, chronic pain, we'll talk about a little bit later, and mental illness. About 60% of people with opioid use disorder have an active mental illness. Examination is focused largely on the comorbidities, so cardiac disease, liver disease, and of course, we're also looking for track marks in various places of the body. Investigations, again, often focus on comorbidities. So we're looking at bloodborne pathogens, and we do want to find out whether people are immune to hepatitis A and B, because if they're not, then everyone with an opioid use disorder should be immunized. And we get a urine drug screen to confirm someone is using an opioid, to see what other substances you're using, and then as treatment goes on, to look at both adherence and continued substance use. It's important to gather collateral information, obviously from other physicians. Pharmacists, in my experience, have a huge amount of information because they see patients more than anyone else, and they often will provide a really useful information about patients. Clearly, we need to look at provincial pharmacy databases, drug information systems, prescription monitoring programs, and if possible, to get collateral information from the spouse, family, significant others. So we're looking at management of opioid use disorder. The first issue, of course, is to determine the stage of change. Where is that patient in terms of their willingness or their readiness to go into treatment? And then we employ motivational interviewing strategies to move people along the stages of change to try and get them to that point where they are willing to or accepting of starting treatment. And then there's management strategies which we can employ at any stage of change. And then finally, throughout all of that, a collaboration. And as I mentioned, particularly if we are starting a pharmacotherapy, collaboration with the pharmacist is essential. So for people that are pre-contemplative or contemplative, then as mentioned, we would employ motivational interviewing strategies to try and move them along. But we would also provide information regarding harm reduction strategies and also provide treatment or harm reduction strategies to help those people that are continuing to use and not at the point where they're willing to go into treatment. So education about safer needle use, needle exchange programs, which are designed to reduce the length of time a needle is in the community and also reduce the number of people that use that needle. It also provides information about how to use needles safely. And then, of course, because people are having contact with healthcare workers, there is a facilitation of accessing treatment if users are electing to go down that road. Supervised consumption sites are designed to reduce overdose deaths, but of course also because of that contact, will facilitate entry into treatment programs. Naloxone kits have been shown very clearly to reduce overdose deaths. Low threshold opioid agonist therapy is basically providing either buprenorphine or methadone with very little follow-up. And safe supply is basically doing the same thing, except using a prescription opioids such as hydromorphone. So safe supply is particularly important in jurisdictions in which the primary substance being used is illicit, either fentanyl or heroin, where the concentrations are never predictable. And so it's a very high risk situation. And so the offering a prescription opioid where the concentration is clear, then that has been shown to significantly reduce overdose deaths. So safe supply, an important strategy, primarily in those jurisdictions where fentanyl and heroin are the primary substance being used. So opioid agonist therapy is certainly the treatment of choice for opioid use disorder. The two substances we use primarily are buprenorphine, which when used sublingually is mixed with naloxone, and methadone. So naloxone is added to buprenorphine to discourage intravenous use of the buprenorphine, because if you do inject it, it will put people into withdrawal. That doesn't mean it isn't abused that way, but it certainly discourages it. So the rationale for both of those substances is that at the proper dose, they will eliminate withdrawal and craving, but result in a little euphoric effect, but at the same time will block the euphoric effect of other opioids, and both substances are given with once daily dosing. So they're very effective treatments. I should mention that when people do present for treatment with opioid use disorder, at that point, almost everyone is using solely because of withdrawal. when people start to use, it's the pleasurable effects that they're experiencing. But once the addiction settles in, basically it's withdrawal that drives the continued use, because about 4 to 5 hours after use, withdrawal starts, and the only way to deal with that is using an opioid again. So if we have a substance like buprenorphine or methadone that will eliminate withdrawal with one daily dosing, then that allows people to get on with their life. The buprenorphine and methadone are basically of equal efficacy as far as reducing opioid use. And there is a significant amount of data now that shows very positive outcomes, significant reduction in opioid use, in HIV incidence, in hepatitis C incidence, in crime, and in overdose mortality, and significant improvement in mental health and quality of life. The data supporting this treatment is overwhelming at this point. So why methadone as opposed to buprenorphine? How do we choose one over the other? The main advantage to methadone is that there seems to be better retention rates. Now, we don't really know why the data is indicating that, but it is consistent with many different studies, systematic reviews, meta-analyses that all show that methadone has about a 15 to 20% improvement in retention compared to buprenorphine. There are a number of possible explanations. It could be that the studies that we're talking about were using a dose of buprenorphine that was too low. It could be that most of the studies are done in the United States, where methadone is only provided in very supervised clinics where there's a lot of counseling and support that goes on. It could be that at higher doses, methadone will cause some degree of sedation or putting people on the nod, which people like. Some people like, I should say, and they're actually looking for that effect, which you won't get with buprenorphine. That's another possible explanation. It could be because of the ceiling effect of buprenorphine. Buprenorphine has a ceiling, so it could be that at higher doses, the efficacy of the buprenorphine is not quite as good. Or it could simply be, in fact, that methadone is going to result in better retention. We don't really know the reason, but at this point, all the data shows that, and so we cannot ignore that. And until other data comes in, we have to respect that result. What that really means is that for people with more severe opioid use disorder, that is people who are using intravenously, methadone might be a better option because the risks of not being in treatment are so significant. The major disadvantage of methadone is its high risk of overdose. It's a full mu opioid, quite a powerful opioid, and certainly overdose risk is there. As a result of that, it takes longer to get take-home doses, so it's a bit more of a restrictive treatment than buprenorphine. It tends to be less accessible because of the stigma attached to methadone, and of course, there's the issue of QT prolongation. So what are the advantages of buprenorphine? Well, there is certainly a lower risk of overdose. As I mentioned, buprenorphine does have a ceiling, and so there's a significantly lower risk of respiratory depression with buprenorphine. As a result of that, we can stabilize the dose much more quickly, and in fact, we can get people stable on a stable dose in as quick as 2 days. And in addition, we can provide take-home doses with the associated flexibility and freedom for patients much quicker. It tends to be more accessible, and it has the advantage of having flexible dosing. So there is the daily sublingual tablets, which is the conventional treatment for opioid use disorder, but there's also now a monthly subcutaneous injection, which is magical, really. For patients who are stable on 8 milligrams or higher, they can get a monthly subcutaneous injection and do very well. And so are sort of free for the rest of their lives to go on and pursue whatever activities they would like without having to go daily or twice a week or weekly to a pharmacy. The 6-monthly implant is for patients on somewhat lower doses, lower than 8 milligrams, not quite as useful as the monthly, but still adding another option for people in treatment. The main disadvantage of buprenorphine, of course, the poor retention rates, but also this issue of precipitated withdrawal, which I'll talk about in a minute. So in the end, buprenorphine we would consider first line in primary care because it's a much safer medication than methadone. And methadone we would consider more for people with severe opioid use disorder, in other words, people with intravenous drug use. I put there the links to the current Canadian guideline for the treatment of opioid use disorder, and also the national guideline for opioid use for chronic pain. So with methadone, the initial dose is usually 10 to 30 milligrams. Ordinarily, we're starting at 30, but if someone is using high amounts of benzodiazepine or alcohol, then we would start at a lower dose of 20. And if they're opioid naive, which is primarily when people are released from incarceration, if they haven't been using, but we know they're going to relapse, we would start at 10. And most people will stabilize between 80 and 120 milligrams. The highest risk of overdoses during induction in the first couple of weeks, and that's because of the very long half-life, 24 to 36 hours, although in people that are methadone naive, that can be as long as 52 hours. And what you get with a long half-life is the potential for drug accumulation. So if the induction is too aggressive, then you can result in overdose death. It's important to recognize that a few days of missed methadone can result in a significant loss of tolerance, and so the dose either has to be reduced or, in fact, people sometimes have to be restarted at the 30 milligrams if they've missed enough doses. So the issue of QT prolongation is certainly present, although possibly overdone. We would do a cardiogram at admission if there's any history or signs of cardiac disease, and if the patient's on any QT prolonging medications. During treatment, for the same reasons, any cardiac disease or any new medications that prolong the QT, but also with a higher dose. The issue with QT prolongation does appear to be dose dependent, and I think if you get the ECG in doses above 100, then you'll probably be quite safe. So the issue of precipitated withdrawal. So buprenorphine binds very tightly to the mu opioid site, in fact, tighter than almost any other opioid, but it has low intrinsic activity. It's a partial agonist. And so if you give buprenorphine to a patient who's already on other opioids, and so mu opioid sites are already occupied, it will displace that opioid, but not replace the effect, and that will put people into withdrawal. And the withdrawal can actually be as bad as Narcan. And so classically, we would want people to be in withdrawal, in opioid withdrawal, before we give them their first dose. So if someone's using hydromorphone or heroin, then if they would use the night before for the last time. They would come in the morning, and they most likely be in significant withdrawal. We would start the buprenorphine. For people that are unable to stop, in other words, they just can't stop enough to go into withdrawal, or in patients who are switching from methadone to buprenorphine because it takes a number of days to get the methadone out of your system to go into withdrawal, then we would do what's called a microdose induction. In that situation, we would give a very small dose, a quarter of a 2 milligram tablet, so 0.5 of a milligram, which is not enough to precipitate withdrawal. And then every day, approximately, we would increase the dose until we got up to about 4 to 6 milligrams. We would continue the other opioid throughout that time, and then at 4 to 6 milligrams, we would start to take the first opioid away. And this works quite well. It obviously takes longer to get people stabilized, but we are then able to get someone on buprenorphine when they're not able to go into withdrawal themselves. Most people stabilize at a dose of 16 to 24 milligrams, and Health Canada suggests that 24 milligrams is the maximum dose, although the literature would suggest that the ceiling is actually 32 milligrams. 24-hour morphine, or known as Schrom, you might know it as a trade name Cadian, is off-label use for opioid use disorder. There's been plenty of studies to indicate that it has equal efficacy to methadone in both retention and a reduction in opioid use. We would use it with failed buprenorphine or methadone trials, or when someone can't take either methadone or buprenorphine for whatever reason. Its main advantage is that it also is effective for chronic pain with once daily dosing. Buprenorphine and methadone can be very effective for chronic pain, but they both have to be given 3 times a day in order to get adequate analgesia. And at least initially, when we're treating opioid use disorder, people are getting those medications once a day, and they would need to get take-home doses to be able to split up the dose. But 24-hour morphine can be given right from the beginning and manage both the chronic pain and the opioid use disorder at the same time from day one. And so it has a significant advantage in that aspect. So obviously, when we're monitoring with opioid agonist therapy, we're looking for both opioid use and opioid withdrawal, both of which would indicate that we have to increase the dose of either the buprenorphine or the methadone. We're looking for adverse effects. The most common is constipation, and we should have a discussion with every patient prior to treatment about how to manage constipation because it's almost universal. The major dose-limiting adverse effect for all opioid agonist therapy is sedation. We will be doing urine drug screening on a regular basis. Immunoassay is a good screening tool, and mass spectrometry, of course, is the gold standard. And then we would also be looking at comorbidities, HIV, hepatitis C, chronic pain, which we'll talk about in a little bit, mental illness, and other substance use disorders. So these all need to be addressed as they occur in addition to the opioid use disorder. Of course, the more services that can be offered on site, the better. But if they cannot be offered on site, then referral would be necessary. And then there's the huge psychosocial issues that loom large when people go into treatment: repairing broken relationships, learning coping skills. Many people start their drug use in their teenage years, and so basically arrest their social development and have not learned how to cope with the everyday life. As I mentioned, mental illness is very common, 60% of patients, and so is childhood trauma. Those issues often come up. Patients who are in treatment, when they were actively using, almost all of their life was spent around their drug use, either getting the money, getting the substance, or using the substance, or recovering from the use. But when they go into treatment, all of a sudden there's a huge amount of idle time which needs to be filled. Housing issues, legal issues, financial issues all have to be addressed. And so we need to provide supportive counseling, sometimes formal counseling, and certainly advocacy to help patients with those psychosocial problems. So when do we taper off opioid agonist therapy? Well, we don't. This is a chronic relapsing disease, and the literature would suggest that when people come off opioid agonist therapy, relapse rates are very high, upwards of 70%. So tapering off is simply not a goal, just like we would not stop insulin in someone with diabetes, nor would we want to stop opioid agonist therapy. Having said that, it's quite common for patients wanting to come off the treatment. And of course, if they want to come off, then that is their right, and we would need to do that. There are really 3 issues that I think will predict successful tapering off opioid agonist therapy. The first is to doing it for the right reason. Wanting to come off because my mother doesn't want me on is a bad reason. For work or for education might be a good reason. The right time is important. So not just when you're free of other substances, but also when you're medically, psychologically, and socially stable. And the right way, which is slow and a patient-driven taper. And if all of these things are in place, then in fact a taper can certainly be successful. Naltrexone is an opioid receptor antagonist, which can be used both for opioid use disorder and alcohol use disorder. The oral tablet, which is given daily, has not been shown to be very effective for opioid use disorder. The retention rates are quite low. The monthly injection has been shown to be much more effective, as is the subcutaneous implant, although we don't see it used very much in Canada. The opioid agonist therapy with buprenorphine and methadone, or sometimes 24-hour morphine, is much more common treatment. Abstinence-based treatments are, generally speaking, not all that helpful. In fact, medical detoxification is contraindicated. There is increased mortality and increased HIV seroconversion connected to it, because what happens is people go in, they get detoxed, so they become essentially opioid naive. They leave detox, they start using again, and they have an overdose. NA and counseling can be very useful for the comorbidities associated with opioid use disorder, specifically for other substance use disorders, but have not been shown to be all that useful for opioid use disorder itself. So let's talk a little bit about opioid prescribing for chronic pain. Chronic pain is very common with opioid use disorder. The majority of patients will report chronic pain. About 2/3 will report chronic pain, and about 1/3 moderate to severe chronic pain. And we prescribe a lot of opioids in Canada. We are behind the USA, which is quite way up in front, a little bit behind Germany, twice as much of Australia, 3 times as much as the UK, 6 times as much as New Zealand. So a lot of people are using prescription opioids, and it's estimated that anywhere from 5 to 8% who are prescribed opioids use them non-medically. And there are many complications associated with opioid therapy for chronic pain: sedation, cognitive dysfunction, falls, sleep apnea, depression, hypogonadism, and of course, addiction and overdose. So I want to talk a little bit about overdose. And in fact, it's not all that high. This is the second misprint. This is supposed to be 0.6 per 1,000 years, which makes much more sense. So that's about 1 every 2,000 person years, which is not a very high number. This is another way of looking at it. Looking at over 2 million people prescribed opioids, and 1 in every 2,500 had either an overdose or life-threatening respiratory depression. So not very high numbers for opioid mortality when opioids are prescribed for chronic pain. Not surprisingly, as the dose goes up, so does the risk. The real problem with opioid prescribing is benzodiazepines. So when benzodiazepines are prescribed concurrently with opioids, the risk of overdose is 10 times greater than the opioid alone. And it's in doses below 100 order morphine equivalents, which is what we now recommend for the management of chronic pain. Virtually every overdose death involves benzodiazepines. So the bottom line here is, do not prescribe benzodiazepines concurrently with opioids. So the risk of opioid addiction then is also an important issue. These figures, at least the top 2 figures, come from the national guideline published in 2017. The overall risk is felt to be 5.5%, and the risk with active addiction goes up to almost 9%. The guideline doesn't talk about the risk when there are no risk factors, but the literature would suggest that, in fact, the chances of developing an opioid addiction when there are no risk factors, the primary one, of course, being a history of addiction, the risk is very low, which is quite reassuring, actually. And what it really means is that we need to identify the risk factors in patients before we prescribe an opioid. Using the DSM-5 to make a diagnosis of opioid use disorder in patients with chronic pain is actually not helpful, because many of the criteria will happen with chronic pain as well as opioid use disorder. So what we end up using are the presence of aberrant behaviors. So things like using the opioid intravenously, purchasing extra opioids from the street, getting from more than one doctor at a time, using other illicit substances, forging prescriptions, stealing opioids, trafficking opioids, multiple lost prescriptions. All of these would suggest that the patient, in fact, has an addiction, possibly diversion. On the other hand, there are many other aberrant behaviors, actually much more common ones. Things like unauthorized dose increases, requests for early refills, identifying specific opioids like hydromorphone, Dilaudid, purchasing Tylenol 1s from the pharmacy. These are all things that make us a little bit nervous, but generally speaking, these aberrant behaviors, these less serious aberrant behaviors, do not indicate addiction. There's many possible diagnoses that I've listed on the right: undertreated pain, increased activity, chemical coping, opioid-induced hyperalgesia, where there's this paradoxical lowering of the pain threshold, withdrawal possibly, and then of course the whole idea of the opioid is just not the right drug in the first place, and it's a failed trial. So these less serious aberrant behaviors usually one of these clinical scenarios that we can sort out. The more serious ones, and these are clearly of a different nature, using intravenously, purchasing on the street, presenting intoxicated, they're the things that usually mean addiction. It can be difficult to tell these two patients apart. It's hard sometimes to know whether we're dealing with addiction or primarily with pain or addiction. I've been doing this work for 30 years, and it can sometimes take me a number of months to really come up with the right diagnosis. So that's okay. Look carefully, get collateral information, particularly with the pharmacist, get objective information with urine drug screens and provincial databases, and look carefully, particularly at the aberrant behaviors over time. And the true nature of what's going on will become apparent. So how do we prescribe safely? Well, there were three sort of primary problems related to opioid prescribing. Prescribing opioids too early in the treatment process, prescribing opioids to high-risk patients, and prescribing high opioid doses. So we need to remember that there is limited evidence for the use of opioids for chronic pain. Having said that, the evidence for opioid therapy is not all that different than the evidence for any other pharmacotherapy, including TCAs, gabapentinoids, SNRIs, and cannabinoids. The issue really is that opioids have more significant complications associated with them. And so most guidelines, including the Canadian guideline, will recommend that we only initiate opioid therapy after failed non-opioid trials. In other words, non-pharmacologic trials like physiotherapy and pain self-management, and pharmacologic trials like TCAs, gabapentinoids, SNRIs, and cannabinoids. And only then, when those trials have failed, should we consider an opioid trial, and it should be a trial. Just like we would not continue with gabapentin if we got to 600 milligrams 3 times a day without any effect, nor should we continue opioids if we get to anywhere between 50 and 90 oral morphine equivalents if we don't get some functional improvement or pain reduction. That would be a failed trial, and we should discontinue the opioid if that happens. So the second problem is prescribing to high-risk patients. As I mentioned earlier, we should not be doing that. And what are the major risks? Personal history of addiction, family history of addiction, history of mental illness, and a history of childhood sexual abuse, probably a history of childhood abuse or sexual abuse at any age, and probably a history of major trauma at any age. But these are the 4 major risk factors. And if we should get this information at an initial assessment, we should define clearly what the risks are. And then if we do define risk, not prescribe to those patients. And of course, the current guideline would say do not prescribe opioids to patients with active addiction at all. And then there's the issue of prescribing high doses. So our Canadian guideline suggests that 90 oral morphine equivalents should be the maximum dose for most patients. And if we do not get significant pain reduction or functional improvement at that point, then we should discontinue the opioid. The guideline does recognize that there will be some patients that will do well in doses over the 90 oral morphine equivalents, and we certainly see this in our clinical practice. I would suggest that if you want to consider going above that dose, you should do it after consultation, either formal or informal, with a colleague that has some experience with chronic pain management. So when we're prescribing opioids for chronic pain, there should be some form of treatment agreement, either verbal or written. Written agreements are probably more appropriate for people who are high risk, but it's quite reasonable to have a verbal agreement in other patients, going over obviously risks and benefits, but also the parameters of the prescribing, things around early refills, lost prescriptions, etc. One thing I would say to you, however, is that every clause in your treatment agreement, if you do use them, need to be that you need to be following those agreements as well. So every clause should be written in that way, because agreements are between two parties. And if you break the agreement, then that obviously is problematic. So make sure that any treatment agreement that you use, you're going to be able to follow as well. We would always be looking at provincial pharmacy databases, prescription monitoring programs as we're prescribing opioids, getting urine drug screens at a frequency based on the risk assessment. So with very low risk, it might be once a year, higher risks, once a month, once a week, sometimes more than that. And then we need to monitor closely and respond to aberrant behaviors. Responses can include things like shortening dispensing interval, getting more frequent urine drug screens, and sometimes even blister packing the opioids and doing pill counts. So what about opioid tapering? So there are three situations where we might want to taper an opioid. With a failed trial, of course, where there's no significant reduction in pain or increase in function, or sometimes a failed titration. If, for instance, someone's doing well at 60 or morphine equivalents and we titrate up to 90 with no improvement, then we would want to taper back down to 60. We would taper with complications, of course, and we would taper with patients who have come to us on very high doses. The goal of the taper depends on the situation. If it's a failed trial, we're tapering to 0, or, as I mentioned before, tapering down to the lowest, the previous effective dose. With complications, we're tapering until the complications resolve, and then we're assessing to see what the efficacy of the opioid therapy is at that dose. With high doses, we're tapering to the lowest effective dose. That means effective outcomes, good outcomes, without complications. 90 or morphine equivalents is not the target for tapering with high doses. 90 or morphine equivalents is when we're starting someone on opioid therapy. If someone's already on a high dose, we don't use 90 as a target. We don't treat numbers, we treat patients. So we should not be destabilizing patients. If we have a patient who is doing well on a high dose, 200 or morphine equivalents, let's say, they're employed, their relationships are good, there's no complications, then yes, we would try to taper because they might do fine on a lower dose. But if they destabilize, we would stop because they're doing well. So we taper to the lowest effective dose. And the Canadian guideline, in fact, that's exactly what it says. Tapers are rarely urgent. Someone has been on their opioid high doses for 5, 10, 15 years. Waiting for a few months is not going to make any difference. Allow people to explore their anxiety because almost everyone feels very anxious. Review the benefits of lower doses and the harms of higher doses, a tough sell for most patients. I'm often using the concept of opioid-induced hyperalgesia with higher doses to try and convince people to go down. And during the taper, obviously, we're always looking to see those positive outcomes and reinforcing them. We should never be tapering at a rate that causes opioid withdrawal. We're always looking for increased pain and decreased function during a taper so that we can slow down. The most important part of a taper is to give control of the taper to the patient. That's when you're going to have success. The idea of the taper might not be negotiable, but how it happens is fully negotiable. And again, it doesn't have to be quick. The patient can decide which opioid to taper, whether it's an SR or IR. If they're already on a benzo, they can decide which benzo, or if they want the benzo or the opioid to taper. They can decide how often to reduce, how much to reduce, when to take a break within reason. And the idea of going at 10%, which is what we see in many guidelines, 10% a week, it makes no sense to me. If anything, you want to start very slow, 2%, 3%. You want the patient to come back the first time saying that wasn't so bad, I can handle that. I predict usually that most of my patients, the taper will take about a quarter of the time that they've been on their opioid. So there's no need to go fast. Take it easy, let the patient decide how fast to go. All right, so in summary, opioid use disorder, the primary treatment is buprenorphine or methadone, and a third line would be 24-hour morphine. For those people that are not ready for treatment, then we would employ harm reduction strategies. For chronic pain, prescribe opioids only after non-opioid trials, avoid opioid therapy in high-risk patients, conduct an opioid trial to a maximum of 90 or morphine equivalents, monitor regularly for benefits, harms, and aberrant behaviors, and taper those patients on high doses to the lowest effective dose, but do not destabilize them. Thank you very much for your attention.
Thank you very much, Dr. Fraser. For those of you who are attending, if you have questions for Dr. Fraser, please put them in the chat, and later on this afternoon, we'll have our question and answer session. Our next speaker, who's going to speak to us about stimulants, is Dr. David Crockford. He is a clinical professor with the Department of Psychiatry at the University of Calgary. He's been a consulting psychiatrist at the Foothills Medical Center Addiction Program, treating patients with concurrent disorders, and is the current academic medical director of the psychosis program of the Foothills Medical Center. He is certified in addiction medicine by the Canadian Society of Addiction Medicine. His published work focuses on education in addiction, gambling disorder, functional brain neuroimaging, and concurrent psychiatric and substance use disorders. He is the past chair of the addiction section for the Canadian Psychiatric Association, as well as prior international area director and international member at large for the American Academy of Addiction Psychiatry. He is a Royal College of Physicians and Surgeons of Canada examiner in psychiatry and prior member of their test committee, as well as a fellow of both the American and Canadian Psychiatric Associations. Welcome, Dr. Crockford.
Thank you. I'm just trying to figure out the technology here, but I should be good. Can people hear me? So thank you for the kind introduction. This is my disclosure, is that I have no commercial interest with pharmaceuticals or any of the cannabis or any other sort of industry. There will be potentially, we'll talk about some of the off-label uses of medications later on. Sorry about that. I had a technical difficulty, and hopefully that doesn't happen again. Let's see if for some odd reason I cannot advance my slides. I don't know. All right. There it is. So we're going to go through the epidemiology and neurobiology of the commonly used stimulants, talk about the short-term and long-term effect of stimulants, and also know the evidence-based management of stimulant use disorders. Stimulant prescribing has definitely gone up over particularly the last 2 decades. That diagnosis of ADHD has certainly exploded in North America, and the perception of risk associated with the stimulants has really dropped. And so we know that when perception of risk goes down, use rates tend to go up around it. There's different types of stimulants which are out there. Probably the most commonly known are the caffeine, as well as nicotine are still the most common. But the big ones that we end up seeing addiction treatment, of course, are cocaine, the methamphetamines, other amphetamines, and MDMA. We see a fair number of prescription stimulants also that people divert in their use as well. And then if you are dealing with the patients from, originally came from outside of North America, occasionally you come across people who are using cat. So I have a number of patients from Ethiopia where this is their agent of choice. I think we've skipped ahead somehow on the slide. Sorry about that. There we go. So methamphetamine, it ends up being, it's really changed the game as far as the stimulants go with the emergency departments and particularly a lot of what psychiatry sees these days. Surveys are not great at picking up people who use methamphetamine. In general, they tend to be people who are not sort of identified in national surveys. But what we do know is that it seems to be much more of a prairie and West Coast phenomena than it is in the East Coast. However, you can find it universally across the country. There's certain populations which tend to be using a lot more, particularly people who are homeless or street involved tend to be using more. Interestingly, same-sex involvement seems to be associated. It's become something with stimulant use and sexual activity seem to be linked behavior. And so it's something which I've gotten into the habit when I have a person who's a primary stimulant use disorder to ask about sort of sexual practices, because sometimes that can be a contributing factor to the relapses to it. We know a lot of people with opioid use disorders also use stimulants. Some mistakenly have the belief that they'll have less risk of overdosing on an opioid if they take a stimulant at the same time. And then Indigenous populations also seem to be overrepresented with stimulant use. We certainly know that the drug seizures by police have gone up, hospitalization rates related to the stimulants have gone up, and addiction treatment visits have definitely gone up related to the stimulants, particularly methamphetamine. However, cocaine is still alive and well and still heavily prevalent. In fact, it's probably a bit more prevalent than methamphetamine, even though methamphetamine tends to get more of the spotlight these days. When you look at, it's this typical 2 to 3 to 1 male to female ratio, much like many of the other substances, and that up to about 14 to 15% of men and 6 to 7% of women have used in their lifetime. Peak use, much like the peak use of all substances, is between the ages of 20 and 24. And we certainly think about between 16 and 25 is when the majority of substances get used. Slightly lower rates for MDMA, or otherwise known as ecstasy, tends to be a slightly younger population too. Typically it was a club drug, but it's you do hear about people abusing it still to this day. The prescription stimulants have also, as I alluded to at that prior slide, have really sort of become more of an issue for addiction treatment providers. So people are getting prescribed prescription stimulants a lot. And then the problem is, though, that about 20% of those who get prescribed a stimulant start to get into problematic use with it, particularly when they're older, when there isn't a clear history of childhood ADHD, there's other sort of traumatic history, people start to divert or use the substances for other effects. So stimulants, now that cannabis is no longer viewed as an illicit substance in Canada, stimulants have taken over as number one as the primary illicit substance of abuse. The common ones that we'll go through are cocaine, methamphetamine, as well as the different prescription stimulants. We'll talk about those with the next slides. Trying to find a bit of humor there. The grandma said in her day that she did 3 times the work that you do. In grandma's day, there was cocaine in the soda. Fortunately, Coca-Cola does not have cocaine in it these days. So stimulants, how do they act? Cocaine blocks the reuptake of catecholamines. The majority of it is dopamine, but it also affects norepinephrine as well as epinephrine as well. The idea is if you block the reuptake in the presynaptic neuron, then more dopamine or the other catecholamines is left in the synaptic cleft. Methamphetamine does it better in that it not only blocks dopamine reuptake, but it also promotes direct dopamine release through acting on the VMAT2 receptor and of the vesicle, which ends up promoting release into the synaptic cleft. So you get more dopamine and other catecholamines present. MDMA, the way that it's slightly different is that it's not only it increases catecholamine predominantly through blocking dopamine reuptake, but it also ends up being a serotonin promoter as well. So it not only blocks serotonin reuptake, as well as promotes the direct release of serotonin. This is part of the trippy effects that people will talk about with MDMA, and that's why they'll have their glow sticks and be looking at them. That's why they would like it at the parties. That quickly wears off, though. So all substances of use, as you learn through the fundamentals course, activate dopamine in the brain. They hijack the dopamine reward system, doing it better than natural rewards. The reason why the stimulants are particularly addictive is that they do it better than all the other substances because they act directly on dopamine. Most of the other substances act indirectly to get the dopamine activation going. So cocaine, that usually is, say, a natural reward. You get a bump in the nucleus accumbens from about 100 to 150. Cocaine, you'll get it between 350 and 400. And methamphetamine, you'll get it up to 1,000, so something which is 10 times the amount of natural rewards. So as you've probably known already, that when a person uses a substance, it activates dopamine release from the ventral tegmental area, which is picked up in the nucleus accumbens for salience, for saying that this thing is important. And it's not only do you get a sense of reward and euphoria from it, but you load it in as being important. So that way, in the prefrontal cortex, it's also registered. So that way, it's planning behavior in the future, as well as you register in other areas. Skip through, sorry. And this is the neurotransmitter looking at the synaptic cleft. And so you can see how the different, how cocaine acts on the presynaptic dopamine transporter, so it blocks it so that we have more dopamine, and something like methamphetamine promotes vesicle release, so you get more, which is present. So cocaine, when you think of powder cocaine, it's otherwise known as blow, coke, snow, naturally occurring alkaloid. You think about places like Colombia and the like, where the coca plants are in Peru, where they're readily available around it. Powder cocaine ends up being snorted, but you can also dissolve it, you can freebase it and use it intravenously. It's a fairly short-acting drug. It's about half an hour to 2 hours. And cocaine is expensive. It's about $100 per gram. Price hasn't really changed a lot, so you go through a lot of money in a hurry with cocaine. Sorry, it keeps skipping back for some reason. When we think about crack is cocaine plus baking soda. The reason why this is important is that when you put the two together, you can cook it, and therefore that you can actually smoke it afterwards. And smoking ends up being a much easier way, that it's easier on the nose, as well as you can rapidly get the effects to your brain. Smoking and intravenous use effectively give you the same sort of effect. And so that's why when people talk about if there's a gateway drug, it's probably tobacco and learning how to smoke and learning how to inhale. And that's why people worry about vaping, is because you teach people how to inhale, and then all of a sudden they have an excellent mechanism to get the effect. Methamphetamines have different sort of names, be it crystal meth, ice, jib. This is clearly ice over here, just because it's used butane. Usually crystal meth has kind of a yellowy tint. It's fairly toxic looking. And the price has really gone down over the years. So now it's about $5 for 0.1 of a gram of methamphetamine. The interesting thing is 0.1 of a gram of meth will almost give you the same sort of effect of a gram of cocaine. The difference is that meth lasts for 10 to 12 hours. The effect is prolonged. People tend to smoke it, but they can still store it, as well as some eject it as well. MDMA often comes in pill form. There's lots of different names for it, be it ecstasy, Molly, E, and X. And it has both these stimulant and hallucinogenic properties. A lot of people, when they say that they're using MDMA, often they've gotten these pills from some source. They have no idea what's in them. It might just be Sudafed. It might just be some sort of caffeine pill. But classically, MDMA is this agent which acts on both the catecholamine system as well as the serotonergic system. So what are the short-term effects of getting intoxicated with a stimulant? Well, people like it, and so there's euphoria, but there's also increased energy. This is the reason why they use it at raves, so that way you can be dancing incessantly. You have, more wakefulness and decreased need for sleep, so people have insomnia. People don't eat when they're taking a stimulant, so they tend to lose a significant amount of weight. And then problems start to occur because your blood pressure goes up and you tend to be tachycardic with it. Over the longer term, these things start to have increasingly negative effects. Psychiatrically, so we already alluded to the problems with insomnia that people have. People can be quite aggressive and irritable when they're using a stimulant. So violence is a significant risk. Paranoia is quite prominent, particularly with methamphetamine. Cocaine, less so, whereas methamphetamine, people can be really paranoid and almost indistinguishable from a person with schizophrenia, except that typically it clears once the effects have passed but it might be days or weeks. People are very chatty during those times. They look manic or hypomanic around it, but again, it fades. There's that lack of appetite, increased alertness, and the irritability around it. I typically do not see slurred speech. If I saw slurred speech with intoxication, I'd be wondering about whether it's alcohol or some other agent which is present, which be it an opiate or be it a benzo, which has also been used. You start to worry about when people are toxic, that they might get dizzy or confused or potentially the risk of seizures. Hallucinations definitely occur with paranoia around it. I often don't see a lot of obsessive behaviors unless they're on the verge of becoming psychotic. And then people in the withdrawal phase tend to have more depression and anxiety. People all knew about with the raves before that people would get hyperthermic. They would get potentially risk for rhabdo around it. High blood pressure. They can also be at higher risk of clotting, as well as strokes, as well as myocardial infarctions. And then there's also potential for damage to liver and kidneys. People, when they use the stimulants, all of a sudden they start tweaking, they get jerky movements. When they use with a significant amount of fentanyl as well, they might get these flailing movements that you'll see some people who are homeless on the street use. It can get so bad that people can actually have convulsions around it. There's often shortness of breath. People are sweating. And a lot of people will talk about grinding their teeth. This is why a lot of people, when they would go to raves, would have soothers in their mouths. And because it's a stimulant, they get pupillary dilatation. So as I've alluded to, there's a lot of complications which are there. The person who snorts cocaine will start getting nosebleeds, and they can also get holes in their septum. They're also higher risk for the myocardial infarction as well as the arrhythmia. Talked about rhabdo, that we particularly see with stimulants. People who are pregnant, they can have placenta previa, abruptio, they can prematurely deliver. We always worry about, particularly the IV user, about developing endocarditis or cellulitis. But people's sexual activity is increased a lot of times with stimulants or is tied to it. And so they have higher risk for sexually transmitted diseases. Being a psychiatrist, I certainly see a lot of people in the emergency department who've been psychotic. And often the story is that they use, particularly meth, they're about psychotic for about 10 to 12 hours and then it passes. The next time they present often takes a couple of days for it to go away. The next time it's often a week. And then some people just flip the switch and they just don't come back around it. One of the telltale signs of a stimulant, particularly meth, but also I see with cocaine, is formication. People talk about bugs that they feel on their body or on their face, and they start scratching. I've had people do surgeries on themselves to remove bugs. That is classic of the stimulants, and probably more so. You don't see that as much with the primary psychoses. So chronic stimulant use, people end up getting irritable, their sociability changes, but it's typically more in the withdrawal phase. They're just dysphoric and they're blunted. When they're acutely intoxicated, they're more hypervigilant, but it's more let's talk about withdrawal, interpersonally sensitive, anxious. They seem to be, their judgment is poor. They're always complaining of inattention. And so a lot of patients, after they've been using for a while, will talk about they need a prescription because they have attention deficit hyperactivity disorder, whereas this is in fact just stimulant withdrawal, which is going on. So what does stimulant withdrawal look like? Well, classically, people would have dysphoric mood. That's one of the keys to it, but they tend to have two or more of the following according to DSM. Certainly they're fatigued. They often have unpleasant dreams. Although they say insomnia or hypersomnia, most people are sleeping more around it. They tend to be psychomotor slowed, but occasionally agitated, and generally they're eating a lot more because they weren't eating while they were intoxicated. That usually clears within 48 to 72 hours, and then a lot of people will rapidly discharge themselves from a detox setting or the inpatient ward to go back to use. The good news with the with the use of different agents that affect dopamine is that, this is a normal, control. This is a person after their absence. So you get blunting of dopamine reward centers, particularly this is the basal ganglia. So there's less activity. You want to see the red colors and so on, which means that there's increased dopamine receptor availability and the like. So you get a blunting, and this is part of the dysphoria. This is part of the inattention that a lot of people with addiction have. And then it takes after about 1 to 2 years, and this is where the lore has always come from 12-step, is that when people have a lot of dysphoria, wait a year and things often get better. And part of it is you get a reboot. You get to actually dopaminergic system activity normalizes with ongoing abstinence. And so that way you can't differentiate a person who, say, was even a methamphetamine use disorder person from a normal control at say 14 months. So longer term complications. And so this speaks to one of the problems with the stimulants is, whereas 10% of regular users of, say, alcohol or cannabis become dependent on it, 10% of single-time users of stimulants end up becoming dependent on it. So people rapidly adapt to this agent, and they quickly develop tolerance and withdrawal symptoms around it. And then stimulant use disorders, they become highly sensitized to it, and potentially there's a number of people who develop seizures. So if you have new onset seizures in a person who's in their 20s or 30s, you think about a stimulant use disorder as the cause. Because it usually, people don't get new onset seizures unless there's some other sort of neurologic insult that's going on. You think about the psychiatric complications. There could be another of obstetrical and gynecological, like irregular menses, particularly if they're underweight. These are the people who perforate their septums and their palates. Might have a loss of sense of smell. They'll have the chronically runny noise when you're talking to them to see that they're sniffing all the time. I was worried about the transmission rates, particularly if they're using intravenously. And then there's this dental caries issue. So not only is it what a person, this is acid, which basically that they're inhaling, can relate to meth mouth, but they're also not taking care of themselves during that time. So that could be one of the contributors. So how do you treat intoxication? For the most part, that it's supportive. You make sure that you limit stimulation, you provide fluids because they're at risk of dehydration around it. You tend to avoid the beta blockers just because, say if they are significantly hypertensive, the problem is if it's unopposed beta blockade, then you get an alpha adrenergic stimulation, and that actually might make matters worse, and people might get into coronary vasoconstriction or ischemia. If they do have elevated blood pressures, or if there's any cardiac symptoms, obviously you investigate them. EKG, you do the biomarkers like your troponins. There's a lot of debate as to if you are going to use an agent, what do you use? Do you use the benzos or do you use an atypical antipsychotic? These days, I think more and more the people used to use the benzos, but because the toxic drug supply and there may be an opioid which is present, if you give them a benzo, all of a sudden they might stop breathing. And so a lot of the EMTs are actually giving people olanzapine to manage their agitation instead. And often that's what we use in the emergency department around it. If you're guaranteed that there is no opioid present, probably a benzo might be all you need. What to do about withdrawal? There isn't necessarily a specific treatment for withdrawal. It tends to be, again, supportive, tends to be symptomatic. And a lot of times people they're heavily sleeping, they're eating more, so they can catch up around it. The one symptom that does come through is a fair amount of anxiety. I tend to avoid using any sort of pharmacotherapy for that. It's more of an acknowledgement and support seems to be where the money is. Oops, keep skipping back, sorry about that. So treatment. Impulsivity is highly problematic with the stimulants. The people tend to leave treatment abruptly. So I have a difficult time trying to engage people in outpatient treatment. It's part of the reason why some of the data suggests that residential treatment seems to be superior than outpatient treatment, particularly at the beginning of their care. The other thing which comes through is that relapse prevention skills need to be instituted early. So talking about drug avoidance, identifying triggers, and particular refusal skills. I'll go through in the next slide what that is. There are no current indicated pharmacotherapy options for the treatment of stimulant use disorders. Some people have wondered about the giving people prescription stimulants for it. So there's been multiple meta-analyses of the trial data around it and what you find is that there's no increase in treatment retention. There's no increase in absence or reduced use rates, except for very short term, but longer term, it doesn't seem to actually be there. There's also high rates of diversion. And what people have found is that people tend to use the stimulant on top of other stimulants that they're using. They'll either sell it to get their preferred stimulant, or they end up just using when they can't access their preferred stimulant around it. It looks like overall the treatment needs to be longer and much more intensive in nature. Sorry, I keep skipping again. I'm going to quickly skip over this. What we know is that essentially the best way to relapse to any kind of substance is you stress a person, you expose them to their cues, so circumstances that they're around when they're using before, or you give them a low dose of their preferred agent. So when we talk about relapse prevention, we tend to talk about high-risk factors. For stimulants, you always think about money. When people have access to money, that is a high-risk factor. So limiting access to cash is really important. You also think about slippery people, places, and things. And so places where people have used, where there's access to alcohol, I tend to hear this a lot with, say, cocaine, is that people identify cocaine as the problem, but they don't realize that it's their alcohol use which lowers their inhibition or puts them in a venue where they can access cocaine is part of the reason for the relapse around it. Talking about cravings and how to manage those cravings at the time, but also looking how to actually, avoid use, avoiding those people and having that initial period of abstinence because people can't reduce their use around it. So I think the final take homes are that, and my apologies for how the slides ended up sort of snapping in and out, and the initial sort of difficulties with my internet. But the stimulants are highly reinforcing due to their direct effect on the dopamine reward pathway. Stimulant use disorder develops rapidly in people who use stimulants, and they can have significant complications, particularly when I think about methamphetamine psychosis, but also cocaine has lots of other sort of physical abnormalities associated with it. Treatment is typically not pharmacotherapy. It's much more psychosocial, and relapse prevention needs to be an early part. But you also think about inpatient residential sort of treatment early on for people with stimulant use disorders, particularly more severe ones. And that's where I'll leave it. I'll be available for the question and answer session afterwards. Thank you very much.
Thank you very much, Dr. Crockford. Just a reminder, if you have questions for Dr. Crockford, if you want to go ahead and put them in the chat now, so we'll have them for the question and answer session. Our next and last session is going to be on concurrent disorders. And Dr. Jennifer Brasch will be talking to us about concurrent disorders. Dr. Brasch is an associate professor and a member of the Peter Boris Center for Addictions Research in the Department of Psychiatry and Behavioral Neurosciences at McMaster University. Dr. Brasch is lead addiction psychiatry for the Mental Health and Addictions Program at St. Joseph's Healthcare in Hamilton. She is also currently the president of the Canadian Society of Addiction Medicine. Thank you, Dr. Brasch.
Thank you for attending my presentation today. Always a bit to get the technology going. I'm pleased to be speaking as part of the Fundamentals of Addiction course today for the Canadian Society of Addiction Medicine, and further to be a presentation on concurrent disorders as part of this talk, part of this course on fundamentals. To begin with, I have no disclosures to report. What I'm hoping to cover today are models of and risk factors for concurrent disorders, an approach to the assessment and treatment of concurrent disorders, and some common patterns of psychiatric and substance use disorders, and some ideas on how to approach managing them. To begin with, let's take a look at the definition of concurrent disorders. And I like this definition from the Canadian Mental Health Association, a condition in which a patient has both a mental illness and is experiencing harmful involvement with alcohol and or other drugs and or gambling. And this little graphic here that emphasizes mental disorders or psychiatric disorders in addition to use disorders, with or without including substance-induced disorders. Of course, it's even more complicated than this in that sometimes the mental health symptoms are due to only to substance-induced disorders. Sometimes they're due to a primary mental health disorder, and separating those out can be, well, I'll use the term tricky, but it can be difficult to sort that out. So we're talking about a complex and a very mixed group of presentations that concurrent disorders is used sort of overall to describe this combination of things, but there's certainly no common etiology or way to make a pattern to these presentations. I will mention that in the US, they tend not to use the term concurrent disorders. You will often see co-occurring disorders or dual disorders. And that can be a bit confusing because in Canada, we use dual diagnosis to refer to people who have both mental disorders and developmental delays. But in the US, they use dual diagnosis, co-occurring disorders, concurrent disorders. I'm not sure which term is best in capturing the idea of describing the constellation of having both mental health issues and substance use disorders. I need to note that I had to produce the slide set about 3 weeks ago, and just this last week, the brand new issue of the Canadian Journal of Addictions was published, and it is a special issue entirely devoted to concurrent disorders. I will be incorporating a little of the new information from that issue, but I encourage you to look it up for the latest on a number of topics and issues related to concurrent disorders. So why should we be concerned about concurrent disorders? To begin with, I will ask you to think about this. What percentage of people seeking help for addiction have a mental illness? So if you think about a substance abuse treatment program, how many of those people are looking for help with or also are experiencing symptoms of mental illness? And it's D, it's 50%. Half of the people presenting for addiction care also have symptoms of mental illness. And those symptoms can make it much more difficult to participate in and to benefit from addiction care. What percentage, let's turn it around, what percentage of people presenting for psychiatric care have a substance use problem? And again, it's 30 to 60%. And I believe that's exclusive of nicotine use, that although those rates are much higher in people with mental illness, that's not included in this data. And again, psychiatric clinics are often not prepared to screen for or address problems with substance use. And for people with both mental health symptoms and substance abuse, it can be much more difficult to engage in and participate in psychiatric care if one is also experiencing substance use problems. Lastly, what percentage of people in an opioid agonist therapy clinic meet criteria for another DSM-5 disorder? And this is a bit tricky because I realized last week in reviewing these slides that the options are wrong. C should be 70% and D should be 90%. And again, the option is D. 90% of people in an opioid agonist therapy clinic meet criteria for another DSM-5 disorder. That might be another substance use disorder, but it also could be depression, opioid-induced mood disorder, an anxiety disorder, PTSD, or many other conditions. So it's important that you recognize that concurrent disorders should be an expectation rather than an exception. That the days of only treating substance use or only treating or only treating mental health problems need to be behind us, that we need to recognize, assess for, and address both. If we look at a psychiatric population, which since I'm a psychiatrist, I tend to do, we know that the first column is the prevalence rates within community sample. So 1 to 2% of the population has bipolar disorder. And within that population, over half of them also have a substance use disorder. As you can see, for all of these major mental illnesses, the prevalence of substance use disorders is quite high, and affects our ability to treat and help these people and help people with these disorders in their recovery. Again, reinforcing the idea that concurrent disorders should be an expectation, not an exception. And as I've already sort of alluded to, the psychiatric disorders and substance use disorders can be combined in many ways. And which comes first, the alcohol use, misuse, or depressive symptoms? Do people use crack cocaine because they have bipolar disorder, or do manic episodes predispose people to go in search of stimulants? Do people use opioids to escape from the hypervigilance, the intrusive memories of PTSD, or does Dilaudid make it much more difficult to treat that? And there are lots of ways to put these things together. And in fact, it's quite a complicated mix of how different psychiatric disorders and substance use disorders can be combined. Lots of risk factors for concurrent disorders, and these will not come as any surprise to you. Family problems, history of trauma, history of concurrent disorders or of psychiatric disorders or of substance use disorders, discrimination in these days of increased awareness of the need for EDI, genetic factors, unemployment, poverty, lack of social supports, and stresses in work or school. And the thing is that these are risk factors for substance use, they're risk factors for mental illness, and they're also risk factors for concurrent disorders. So I don't think that's a particular surprise. And I think, complex as it is, we can all appreciate that the social determinants of health are substantial factors in the development of concurrent disorders. And the color pictures are from scenes around Hamilton, unfortunately. And you think about it, someone's living in poverty, if they have, I'll say $20, either that's left over or that perhaps they found, or one, you can't use $20 to help you escape from poverty, from bed bugs and cockroaches, from not having enough food till the end of the month, from not having meaningful activities in your life. You can use $20 to buy methamphetamine, which will allow you to escape the stress and dysphoria of your life for at least 12 hours, perhaps considerably more. And much as we dislike thinking about it, substances can be a way to escape one's difficult circumstances, at least temporarily. And I think being aware of that has made me much more sympathetic and understanding of the struggles that people with concurrent disorders face. I'm guessing that at least some of you are familiar with the Adverse Childhood Experiences study, which was a huge survey of about 18,000 people in a large HMO in the US in the late 1990s. And 18,000 adults were assessed and questioned about health conditions, substance use, physical health conditions, and behaviors that would lead to poor health conditions as adults. And then they were also asked about early childhood experiences, and specifically adverse childhood experiences, which were lumped into these three categories of abuse, neglect, and household dysfunction. And so those were the adverse childhood experiences, and these were the physical and mental health conditions and behaviors that were asked about in terms of adults. And unsurprisingly, there was a direct correlation between the number of ACEs and the experience of mental or occurrence of physical and mental health conditions and engaging in behaviors that would lead to poor health outcomes. In fact, people with 4 or more ACEs were at least 10 times as likely to use IV drugs, and also had much higher rates of suicide attempts than those with fewer ACEs. Leading Dr. Sumrock to point out it's not the drugs, it's the adverse childhood experiences, and examining addiction as ritualized compulsive comfort seeking as a way to seek escape from the effects of trauma in early childhood. And this speaks to the complexity of concurrent disorders and the difficulties in helping people recover and move forwards in their life if a person has experienced substantial numbers of adverse childhood experiences. So I need to emphasize that there's a complex interplay of different factors. Any diagnosis from either category can cause, potentiate, or predispose to the other. Different models have been developed, and no one model explains everything. At one point, there was consideration, does having a psychiatric disorder predispose to substance use? Well, that may be true for some conditions, but certainly not for all of them. Does starting substance use predispose to the development of a psychiatric disorder? And again, probably in some cases, but not in all of them, because we're certainly well aware that many psychiatric disorders start early in adolescence, before the beginning of substance use. And likely for many conditions, there's a complex interaction that mental health symptoms may predispose someone to start using substances, which then worsen or exacerbate the mental health symptoms, which lead to increased substance use. And there's this back and forth that makes each condition more severe and leading to poor health and mental health outcomes. Overall, people with concurrent disorders have much more guarded prognoses than either people with substance use disorders or mental health problems, that the combination leads to much poorer outcomes. That the people with concurrent disorders use more services. They feel like system misfits because they don't fit in either addiction services or mental health services. They're often not wanted by either. They're highly crisis prone, and they're much more difficult to engage in a positive and hopeful way. And depending on the settings in which you work, you can think about someone presenting to the emergency room with alcohol use disorder who's feeling suicidal and expressing thoughts of ending their life. The staff person or the social worker or the mental health worker in Emerge calls the addiction, the withdrawal management service, and they say, what? They're suicidal? Don't send them here. So then the staff person calls the mental health program who says, what? They have an alcohol use disorder. We can't help them. Don't send them here. So what happens is the person doesn't get help because neither service will take them. And this speaks to the complexity and the challenges, and for people with concurrent disorders having much more guarded outcomes. Assessment is difficult. Primarily, the issue seems to be around sorting out whether it is a primary or secondary mental health condition. So are the mental health symptoms due primarily to a primary psychiatric disorder, or have they arisen from the use of the substances? And that can depend on the state of the substance use. Intoxication can mimic certain mental health conditions, depending on the substance, of course. Withdrawal can appear to be a different mental health conditions. And then there can be substance-induced conditions where ongoing use can lead to the mental health symptoms. And I know you had a presentation this morning on assessment and the importance of exploring all facets of substance use, particularly I think within both the mental health and the substance use communities, services, that it's important to ask both about substance use and about mental health symptoms. I recognize screening for every mental health disorder is not feasible in many assessments, but exploring anxiety, depression, psychotic symptoms, suicidal ideation is important, as well as exploring for use of common substances and whether that may be a common influence. One way to look at it is to get away from pigeonholing people into diagnostic categories, which, although it has its benefits, also has limitations, and to examine this dimensional approach, the interaction between mood symptoms and substance use, as well as these other dimensions of mental illness, anxiety, psychosis, impulsivity. Right, we know that impulsivity is a significant criteria in a number of mental health disorders and can lead to increased substance use. And then we also know that use of certain and many substances can increase impulsivity. So there's an interaction there. The other way to look at the dimensional approach is to look at how mental health leads to the interaction with different substance use, subgroups of substances. So is a psychiatric symptom primary or substance induced? There are a number of categories that we need to look for. Depressive symptoms can be due to a primary disorder or can be substance induced, as can any of these, right? Hypomanic or manic symptoms, anxiety, insomnia can be induced by a number of substances, but you also can have a primary insomnia, or insomnia is part of many primary mental health conditions. Right, mania and depression are certainly associated with insomnia. Anger, not a DSM diagnosis, but present in a number of conditions, psychotic symptoms, and then cognitive impairment. Substance use disorders, we can categorize, we can say it's a substance-induced mood disorder, and what one would do is attribute that to the major substance. So one could have an alcohol-induced mood disorder, or a stimulant-induced anxiety disorder, or a benzo-induced anxiety disorder, right? Many substances can induce neurocognitive disorders. Sorting that out, there are a couple of tricks or ways one can look at doing that. One needs to look at mental health symptoms present around the state of acute intoxication or withdrawal, and during 1 month, so the acute state. And although the identification within acute intoxication or withdrawal is important, those are often quite relatively brief states. From my work within concurrent disorders, it is the ongoing presentation of mental health symptoms in the context of substance use that I want to sort out. But if you're going to make an identification or a diagnosis of a substance-induced disorder, you need to be certain that the involved substance is capable of producing the mental disorder. And again, that's often not all that straightforward, but a way of looking at it and recognizing that abstinence can help sort out whether it's a substance-induced disorder. For example, anxiety psychosis may resolve with the achievement of abstinence from substances, as can depressive symptoms, but that certainly isn't always the case. With heavy and chronic use of a substance, it can take over 6 months of abstinence for some substance-induced psychiatric symptoms or cognitive changes to reverse. For example, the sleep-wake cycle disruption of alcohol use can take 6 to 9 months to resolve after achieving abstinence. If a person has misused benzos, it can take months of abstinence before symptoms of benzo withdrawal, which mimic a number of psychiatric disorders, and the insomnia resolve. And that can be very difficult for people to tolerate if that goes on for months. So is a presentation, are mental symptoms substance-induced or not? Helpful to use a timeline. You can look for psychiatric symptoms before the onset of substance use and during periods of abstinence. So for example, say someone has had alcohol use disorder for 10 years and they're 40 years old. They started using alcohol in a well above low-risk guidelines when they were 30. Then you could ask about depressive symptoms before they were 30. Did they have episodes of depression before in their 20s or even in their adolescence? And during this 10 years, what was the longest period of abstinence? Say they had a period of 6 months when they were abstinent. Did they have depressive symptoms throughout that period? Primary psychiatric disorders will have periods of abstinence, will wax and wane separately from the substance use disorder. Symptoms, mental health symptoms that are substance-induced will have their onset and offset concordant with the use of substances. So that's useful to sort it out. Oftentimes, I will be quite upfront, you can't sort it out, that people can't give a clear history, or they don't remember, or it's really not that clear. If someone's only managed to achieve periods of abstinence of 1 month, it's really hard to determine if their mood disorder symptoms, for example, are primary or abstinent or substance used, because they weren't abstinent for a substantial period of time. Beth Reed told me that primary psychiatric condition may or may not be present, and time will tell, and that's true, but maybe you don't want to wait that long, that you want to help the person. So which to treat first, addiction or mental illness? I'm going to suggest that you need to start with safety and survival, that these are a priority. Of course, it's going to depend on the context in which you're working and assessing people, but depending on the context, you must focus on safety and survival. No matter the diagnoses, primary or secondary, or which symptoms of substance and mental disorder are present, you must treat suicidal ideation, psychosis, and psychosis that's affecting a person's behavior and ability to care for themselves, risk of violence, and dangerous withdrawal. Once those survival issues and safety have been addressed, then you can focus on addiction and mental health treatment. And I don't think it's any surprise that a brain has to be somewhat clear from substances to begin to learn new skills. And I think that's an important factor. That's not medication. Learning new skills, relapse prevention, learning to live without substances, your brain has to be clear to be able to do that. Pills won't do that for you. Lots of barriers to treatment for people with substance use disorders. Stigma and denial. I mean, they're problems for people with mental illness or substance use. It's an even bigger issue for people who face with concurrent disorders. Not having all the diagnoses identified, trying to treat someone within an addiction service for alcohol use disorder and not recognizing that they are depressed or that they're struggling with PTSD will make it really hard for them to engage in treatment and to benefit from treatment. The complexity of the presentation. I can spend an hour and a half with patients and still feel I haven't sorted it all out or even know which came first or which is most important. Not being aware of treatment options and of different medications and talk therapies. Challenges in navigating addiction and psychiatric systems, particularly if there's not an integrated service to support people. And then problems that face people not only with concurrent disorders, but with substance use or mental health problems. Difficulty affording treatment, getting time off work, unsupportive family, and other responsibilities that make it hard to engage in treatment. When I was a medical student and a resident, we didn't treat concurrent disorders. We went after sequential treatment, which meant that first a person went for addiction treatment and then for psychiatric care, or the other way around. As you can imagine, that tended to not be successful with one service not wanting to treat people struggling with the other condition, and often people did not get treatment and could not and were untreated. Parallel treatment refers to receiving both psychiatric and substance use treatment, but in different services, often with services that don't talk to each other and may have different philosophies or approaches to treatment. This can be very difficult for patients to navigate two different systems and to try to resolve different approaches. For example, there are still some substance abuse treatment programs that are abstinence-based, and not only abstinence from substances, but also abstinence from any medications. Whereas mental health systems, treatment programs often recommend or prescribes medication to help with recovery. Trying to navigate both of those systems can be very difficult. Integrated treatment means one-stop shopping where clients can receive treatment for both mental health and and addictions care in one service with an integrated treatment team. It appears to be more costly, but overall leads to better outcomes and less presentations for emergency care, leading to overall lower costs. The SAMHSA, which is the American Organization, Substance Abuse Mental Health Association, supports an integrated approach and have found integrated treatment leads to lower costs and better outcomes. I probably do not need to convince you of that. One way to understand this is to look at placing the services in your community within a quadrant, a diagram in which you put mental illness severity along the x-axis and substance use severity along the y-axis. And the idea here is that patients with low mental illness, low substance use, or even low mental severity in both can be managed and treated within primary care. But as severity of conditions increases, specialized care are needed, and for people with concurrent disorders, an integrated approach is required. One of the important aspects with this quadrant idea is that there should be no wrong door. That if a person presents to an addiction service, but it's recognized that they have significant mental health symptoms that will make it difficult for them to benefit from specialized addiction care, that instead of being rejected and declined service, that they are passed over or referred to an integrated program or offered some enrichment within the addiction care to address their mental health needs. The idea is that there be no wrong door to seeking care. And this is from a 2019 paper looking at models of concurrent disorder service and looking at emergent models of concurrent care and emphasizing that collaborative care and all these other aspects, sharing information, cross-training, including allied health professionals, is important for effective concurrent care. This is feeling a little dated, but CCSA put out a report on concurrent disorders. And what they did is they grouped concurrent disorders into 5 major categories. I won't speak to these specifically, but I think it speaks to the different sort of needs of these different groups and the needs for specialized care, since not one, how do I say this? Concurrent disorders isn't one thing to everybody. People need specialized care depending on the mental health and substance use that they're struggling with. Although I'm sure there have been a lot of discussion of pharmacotherapy today, and pharmacotherapy is absolutely important in concurrent disorders care, I need to emphasize the benefits, importance of talk therapy for people with concurrent disorders. And we know for mental health disorders that combined pharmacotherapy and psychotherapy leads to better outcomes. It's no surprise that this is important for people with concurrent disorders as well. And that, of course, can take a number of different formats, individual versus group, in-person versus online, and of course, much more online work now, and the value and benefit of mutual support groups, which for some people are invaluable and are not helpful for others. And then there are, and what's offered may depend on lots of things, including funding models and availability of services and the capacity of a person to pay for individual service. And there certainly are many benefits to group treatments. There are a number of different evidence-based treatments that are effective for use in a concurrent disorders population. Motivational enhancement to help people want to make changes in their substance use, skills in distress tolerance and emotion regulation, and of course, this is basic DBT skills. People use substances in order to cope with strong emotions. We can't expect them to stop if they don't have other skills to be able to cope with strong emotions. Relapse prevention, effective for substance use populations and also for people with concurrent disorders. Acceptance and commitment therapy is a very powerful, brief intervention based under very colloquially or briefly the idea that acknowledging that there are likely traumas and painful events, memories that you live with, but this does not prevent you from living a good life now. And how can you move forward? What can you work on now to help yourself live a better life and have more value and meaning in your life? Cognitive behavior therapy can be effective in this group. And community reinforcement and family training, well known within the psychology community, less so within a physician-based group. And this is the idea of teaching caregivers, family, friends, or a therapeutic community to reinforce desired behaviors and extinguish undesired behaviors. Within my clinic, there is a new group that's just started offering craft therapy for the parents of young adults with substance use disorder. And the idea behind craft therapy is that there's a reinforcement of desired behaviors so that the family member says, we'd like to go pick an activity we can do during social distancing. We're going to go for a hike, or we're going to go over, get takeout for dinner. If you are sober and not using on Saturday, you're welcome to come with us. And reinforcing that, great, you didn't drink today, you're sober, so glad you can come with us. And if the person drinks, well, I'm sorry you're not able to join us today, and leave and go and do the pleasurable thing. so that you don't nag. The family learns not to nag and to reinforce or focus on negative behaviors, but to reward and encourage positive behaviors. Very powerful intervention, and offers a very constructive way that family members can help move their loved one towards recovery. Sorry, we skipped one. No. So let's look at a few groupings of common presentations. This is anecdotal, but these are groups that I see. People with post-traumatic stress disorder who have been using alcohol to cope and to suppress the PTSD symptoms. These people may meet criteria for or have significant depressive symptoms and are feeling life is pretty much out of control. First off, I tell them that things may feel worse with abstinence. I think it's really important to give that message. I do not wish to be demeaning, but often the recovery community wants to promote the idea that if you stop using, you'll feel better. And for people with concurrent disorders, including PTSD, they can feel worse because they have been able to suppress some symptoms with their substance use. So it may get worse with abstinence. And if you provide that information, it's helpful to people. I'm using trazodone and prazosin to suppress the nightmares. These can be quite effective. I will prescribe starting with low doses and in small amounts to minimize the risk of misuse, particularly if the person's not able to stop using. I use gabapentin. I also use naltrexone in this population, and acamprosate. They're not on the slide, but I certainly will offer polypharmacotherapy here. This group can benefit from cognitive processing disorder, which is an evidence-based group treatment for CPD, but they need to have skills in distress tolerance and emotion regulation and have their substance use managed in order to tolerate this. It's quite a difficult treatment to take part in, but they can work towards that. And if you can suppress the PTSD symptoms, that's very helpful for the recovery. I see a lot of people who have been using opioids or alcohol to cope with social anxiety disorder. And this is a good one for a timeline because usually symptoms of social anxiety begin in adolescence. You can ask people what high school was like. Were you able to give presentations in class, or would you take a 0 on the assignment? And that would be before they started using opioids or alcohol, usually. And again, and you also know that in university or college age, let's just say young adults, it's actually considered socially acceptable to have several drinks before going out for social events. And at some point that becomes pathological and maladaptive instead of just a way to save money. Again, that can get worse with abstinence. I treat early with SSRIs. Again, I'll use naltrexone, but I will often offer gabapentin because that has some calming effect for a lot of people. Since I put this slide together, I do my absolute best to stay away from benzos. It's just risky, and certainly if someone on opioids, I don't want to start those. It'll just give them more problems. Benzos are definitely a double-edged sword. We want to try staying away from that. I'm hoping that you have come across the Da Vinci study that looked at an evidence-based structured approach to treating symptoms of depression and alcohol use disorder. This was done at CAMH and was an elegant design, double-blind, placebo-controlled trial of sertraline, naltrexone, both or neither. And they took patients with symptoms of depression and alcohol use disorder. They did not try to sort out if the depressive symptoms were primary or substance-induced. They just randomized them and off they went. And you can see from this graph that naltrexone or sertraline did not have a significantly different outcome from placebo, but both together did. So this differs from the Choosing Widely Canada guidelines, which encourage a period of abstinence for people with depressive symptoms and alcohol use disorder before starting an SSRI. Because this shows, the Da Vinci study shows that giving both upfront was more effective than either alone. And generally, and from my perspective, SSRIs are inexpensive, they're very safe, so I treat early. Of course, I'm in a concurrent disorders clinic. I see patients who failed out of treatments, who have quite severe symptoms, and I recognize there are other practice symptoms settings. But I want to encourage you to, if it's in the setting you practice in, to encourage both naltrexone and an SSRI not to wait before starting those. This is a study from last year. This was a systematic review and meta-analysis. And this looked at 32 studies looking at the pharmacological treatment of mood disorders and comorbid addictions. And it was quite a mixed bag of studies. And so the outcomes were really, I'm going to use the word tepid. There was no sort of resounding treat early, treat aggressively. They did find that pharmacological treatments were significantly better than placebo for manic symptoms, depressive symptoms, and alcohol abstinence, but were not of much help in bipolar depression with comorbid addictions. But then treating bipolar depression is very difficult with or without substance use. Quetiapine was not more helpful for bipolar depression, particularly in substance use, nor were SSRIs, although the studies were quite modest that looked at this. So that the findings highlight the need for further high-quality trials, and I think that's basically what I took away from this. Methamphetamine and psychosis. First of all, methamphetamine intoxication can cause an acute psychosis. People can be very violent. I want to speak now about someone who's used methamphetamine chronically or for a period of time. Sooner or later, anyone with ongoing use of methamphetamine becomes psychotic. It's just a matter of time due to damage to the dopamine neurons. People tell me, or at least my perception is that it's qualitatively different than a primary psychotic disorder, that people report that they are aware they're psychotic and that their brain is generating the delusions and auditory hallucinations. This can persist for months after stopping methamphetamine use and will then reoccur much more quickly with re-exposure to stimulants. I do use antipsychotics. I have found no evidence that first generation versus second generation are more effective. So I cannot offer any great guidance that way, except to say, treat it. I know that there are clinics like the Brantford Ram Clinic uses bupropion and mirtazapine. I don't think that's going to treat the psychosis, though. And I think the evidence on whether that's effective for reducing relapses is mixed. I do not use stimulants in this population. Got to speed it up here. Cannabis and psychosis, two excellent, not only psychosis, but mood disorders, two excellent reviews in this Canadian Journal of Addictions. Highly recommend looking at them. We know that the studies or the systematic reviews show that there is an increased risk of psychotic disorders, bipolar disorder, and cannabis use disorder associated with earlier onset of the mood disorder, of the bipolar disorder, and associated with earlier use of cannabis, of a higher potency, and of daily use, and earlier onset by about 3 years, which is significant. I see people with amotivation syndrome. Really hard to work with this group because they don't want to stop using the cannabis, which of course is inducing the amotivation. And I'm now guiding the family members into this CRAFT syndrome, CRAFT treatment group that we're running, because I think that's one way to perhaps help them. ADHD, big risk factor for substance use disorders. Recommend objective evaluations. And again, a timeline that I'm not going to treat ADHD symptoms that started after the onset of stimulant use. I would really like to see school reports demonstrate that document ADHD before someone started using stimulants. Before stimulant disorder. I will not treat someone who continues to use stimulants in an addictive way. That can be difficult to sort out. And using substances to cope with strong emotions. It can be a history of course, the self-harm and impulsivity. And I emphasize skill training to do this. Insomnia, I don't have much time for this, big problem. And people with substance use disorders are used to using a pill to fix things, and providing that, feedback that, insomnia is not the end of the world. You will sleep. Look for concussions. You under assess for these, and they can appear, a patient can look like they're non-compliant, but in fact, they may have cognitive impairment from a concussion. It's important to look for it, and we generally don't. I want to spend 1 minute talking about the Concurrent Disorder Clinic, because I want to tell you that we are now we were running drop-in groups before the pandemic, and we have shifted all our groups to virtual, which means you can go to this website. You do not have to be a client of our clinic to attend these groups, and they're drop-in for anyone. And we are offering motivational enhancement, basic DBT skills. We have a smart recovery group. We use ACT, and we're offering both a drop-in format and a closed structured group. Our post-acute withdrawal syndrome group looks at how do you build a life worth living or a meaningful life after you've stopped learning, stopped using. So it helps people to rebuild or build a new life, and looking at aspects of that. And then we offer a psycho-ed group. This is different from the craft group. And family and friends find that helpful. Happy to talk more about this during the question session. I certainly do not see everyone referred to our Concurrent Disorders group, and I see only the difficult ones that they feel would benefit from a psychiatric assessment. And we work together and support each other. It's an important part of doing this work. So there's no one correct approach to individuals with concurrent disorders. True concurrent disorders care is when a client can talk openly about both their substance use and their psychiatric state, and appreciate the interaction between the two, and you can be open in addressing both of them. Thanks very much for your attention, and thank you for your interest in addictions and addiction care.
Thank you very much, Dr. Brasch. I'm going to now transition us to the question and answer period. I'll just remind people, I know you have been putting some of your questions into the chat. If you have additional questions, please continue to put those into the chat for the panel. I already have quite a few questions here to move through. I think I'll start with one that's a question for all of the panelists. And the question is, how can we help patients navigate treatment systems and identify accessible, affordable, and evidence-based options, especially when wait lists mean private residential treatment is often the first available route? Who would like to start on the panel with that one?
It's a very hard question. I'm not sure that everybody is sort of pausing to kind of answer it. I think it's across Canada, that is a major issue, is that all of us have difficulty accessing care for patients when they're ready to actually to make changes. I know, fortunately, in Calgary, that I work with a group where that some of the people work in the detox center that we have, some work in the residential treatment program, and that we can try and fast track people. And if they're to get them into detox, that the way they're identified at detox and can go door to door to the Clarisome Center for Mental Health and Addiction. But that's uncommon. And I don't think there's a good answer for that one. Maybe my colleagues have a good answer for it, but I honestly can't think of one.
Well, I'm not sure there is a good answer. It obviously depends on where you are in the country. In the end, I think the answer is a long-term one. Clearly, there needs to be more funding that goes into addiction medicine prevention and treatment. But maybe even more than that, there needs to be significantly more education that occurs at the undergraduate and graduate level, so that physicians and other healthcare practitioners become aware of the issues and knowledgeable, and become then interested in being involved in management. those are the kinds of initiatives I think that will make a difference. The stigmatization that exists in the general population is just as prominent now in the healthcare system that I can see as it always has been. And that's a significant barrier. And I think in the end is going to be the way that we answer the question that you've got.
I think it's really important to be aware of all the services and supports in your community, so that if you're practicing in mental health, knowing what the addiction services are, so that you can talk with your patient about them, even if you aren't directly referring or working with them. I also think it's important that people, that we use online resources, that since the advent of transitioning there's so many more virtual services and supports that have developed during the pandemic, that if you are in a community that does not offer certain types of treatment or therapy, you may be able to access that online, right? There's things like intherooms.com that offers access to 170 mutual support groups around the world. So no matter what time it is, you can join a support group. Or if you're in Ontario, you can tell patients to refer themselves to Bounce Back, which is a CBT program for anxiety and depression that provides individual coaching, and it's paid for by the government of Ontario. So this is a way to expand things. I certainly am aware that many people with addictions or living with below the poverty line have very limited access to virtual resources. But it is one way to increase access. And there are some services, like I know at our withdrawal management service, that they will help people access online support groups when people are staying at the withdrawal management service. So that's one way to expand access to care.
I think just to add, obviously it's different across the country, but within Ontario, there's been a few innovative developments that have helped people access care. So first of all, there's the rapid access addiction medicine clinics, of which there's 50 or 60 now in Ontario, that at least give people a starting point where they can access care and hopefully be connected with other services. There's also in my region and spreading to the rest of Ontario is Access Mental Health and Addiction. So it's a coordinated access where individuals can connect and determine if they're looking for mental health and substance use and be connected and matched to the right service. Now, both of those things do not necessarily increase the number of services that are available. And I echo what other panel members have said about there being a need for an expansion of services that exist. Okay, so I have some other questions. This one's for Dr. Crockford. Can anyone comment on concomitant alcohol and cocaine use in the management of withdrawal or decreasing cravings? I've used gabapentin with some benefit. Wanted to know if there were other options to consider, topiramate or other options.
So it sounds like, the data is predominantly present for the alcohol use disorders, and there's very little data looking at concomitant alcohol and cocaine use, and at least trial data that I'm aware of. There is a small study that Kyle Campman did out of the Pittsburgh group, looking at topiramate for the treatment of cocaine use disorder. Very small, and it was modestly positive. I don't think you're going to have a specific pharmacotherapy, though, that's going to be the be-all and end-all around it. As far as managing withdrawal, I think if it's alcohol use disorder, the best data and the Cochrane reviews suggest that it's the benzodiazepines are the best ways to manage acute detoxification, particularly on an inpatient basis. I still use, the benzodiazepines sometimes with an outpatient taper with a medication like, say, chlordiazepoxide, because you can just load them for 2 to 3 days, and then they self-taper because the drug has such a long half-life. It certainly is that alcohol use is problematic as a precipitator of cocaine use. And so that's why I think most people try and address them at the same time, even though that the patients often will be focusing more on the problematic one, which tends to be more the cocaine, just because of the cost around it. It's a long-winded answer, and I'm not sure if I actually answered the question at the end of it. So my colleagues have some good ideas.
Well, actually, I want to ask you a brief follow-up question to that. Evidence aside, I want to know what you do. I want to know what you do with the patient with a stimulant use disorder who's an inpatient who's threatening to leave AMA, and how do you keep them in the hospital?
Well, that's a very hard question.
I'm not asking for evidence. I'm asking for what you do.
I know, and so, you know, I'm really loath to take away people's rights. And a person who is adamant on leaving, if they're not certifiable that they're representing an imminent danger to themselves or others, or there's a significant risk of immediate deterioration, even though that I know that they're likely going to be leaving to use or to relapse, I don't think I can bar them from that. I can try and negotiate with them and speak to the reasons why they're in hospital and why we're trying to connect them with care, so that way they don't return to the difficulties that they have. But there isn't something beyond that I necessarily could do. Maybe you have a good idea, John, as to what you would do, because I've yet to come across one.
Well, for sure, we let people go if they want to go. I mean, that's of course, but I'm wondering if you have any sort of suggestions from a pharmacologic point of view that might help people stay in without leaving.
Yeah, not that I'm aware of, and not that I've necessarily offered. Like if they're in significant withdrawal, I don't think there's a good agent for stimulant withdrawal, which is out there that would convince a person to stay outside of.
We give stimulants, and it seems to work sometimes. To give them a prescribed stimulant, and it seems to be helpful. But I'm just wondering if there was something that you had.
No, I wish. I don't have a good one there.
So there's several questions about buprenorphine. So the first question is, are there any disadvantages with using monthly buprenorphine injections or subcutaneous depots compared to daily dosing?
No, I don't think there's any significant negative. I mean, the problem with the 6 monthly is that usually we're talking about patients on lower doses, and not that many people are stable on those low doses. But with the monthly injection, it's in the dose range that people are usually at, and it functions very well. It's really an amazing treatment.
The next question is about Dr. Fraser, your experience with Suboxone for chronic pain patients who have aberrant behaviors on opioids, example, snorting purchase streets opioids.
Yeah, so buprenorphine is certainly an effective treatment for chronic pain as well as opioid use disorder. If as I said before, it needs to be taken 3 times a day, generally speaking, and it is abused, but not as much as other opioids. I tend to use the 24-hour morphine product in those situations a little bit more. Because if someone has significant aberrant behaviors, that can be administered in a once daily witnessed situation. And so it might be a little bit safer. But as for when you consider all of the opioids that we use, certainly buprenorphine is the safest if you're talking about giving some for them to go home with. So it is a useful agent for chronic pain, and current evidence suggests that the ceiling that we see with other actions with buprenorphine does not appear to exist for pain, and we can actually go up higher than the total daily dose of 32 milligrams in some patients.
The other question, although I think you've probably answered it, is around Suboxone and in patients with chronic pain. Is it effective, which I think you've answered? And then is it true that most do well at a lower dose of Suboxone versus the recommended dose for substance use disorder?
Absolutely. If you're using buprenorphine for just pain, and there's no addiction involved, for sure, we are usually talking about much lower doses. I have patients who are on, 1 milligram twice a day, sublingually, who are doing very well. It's actually quite powerful as far as an analgesic is concerned. And so you can get by with very low doses in patients when you're just treating chronic pain without the presence of opioid use disorder.
Okay. So here's another question. What is the end game in the safe supply program for opioid use? If patients are being prescribed large amounts of PO morphine or Dilaudid, but the eventual goal of any addictions treatment is abstinence, decreasing tolerance, etc., then where does safe supply fit within these goals?
So the goal of harm reduction is not abstinence, it's harm reduction, it's reducing harms. And while we are doing any kind of harm reduction strategy, whether it be safe supply or otherwise, we're hopefully continuing to keep contact with our patients and using motivational interviewing to try and move them along the stages of change to get to the point where they are interested in treatment. So it's a matter of continuing to work with people to get to that point. And while we're waiting for that to happen, we're employing whatever harm reduction strategies seem appropriate in order to reduce the risks, including overdose, but also HIV, hepatitis C, and others.
Thank you. So if there's any other questions, please put them in the chat. While we're just waiting to see if there's any more questions, I just want to remind everybody to fill out the evaluation of the course. It's on the midway bottom right of your screen. It'll say take survey. You need to complete this in order to get your certificate of completion. If you complete it today, you will receive that certificate of completion by the end of October. You will be able to still complete the survey within the next 30 days, but if you're like me, you're best to do it today, or you may forget and not complete it. So just want to remind people to complete that survey. I'll just wait a few more minutes and see if there's any more questions that anyone wants to put in the chat.
So actually, I'd want to open up my question to everyone else on the panel, because it is a problem that we come across with our addiction consult service is the person with stimulant use disorder who's threatening to leave. And if anyone's had any success, pharmacologically or otherwise, in trying to help people stay in as an inpatient. Anyone else with experience?
I don't have much experience with this. I suspect that there are a lot of factors that will determine whether or not they leave. I have heard of using stimulants. I have not prescribed that. Do you use short-acting, like short-acting Ritalin?
Yeah, well, to be honest with you, we use what the patient wants.
That's
I mean,
fair.
we go to them and say, what can we do to keep you in the hospital? And these are the things that we can provide, and we let them choose.
And I think that's a very supportive approach. I'm thinking of a recent case in Hamilton where I think stigma towards the person with substance use was likely an even bigger factor than withdrawal symptoms in their decision to sign out AMA. And that we see more and more patients admitted with concurrent disorders. Unfortunately, attitudes towards addressing concurrent disorders and substance use on psychiatric units or medicine units is lagging. And until that begins to shift to seeing this as part of acute medical and psychiatric care, I don't know how much prescribing stimulants will help.
Yeah, I agree with you 100%. I mean, the limited evidence we have is that stigma is the biggest driver towards leaving AMA.
Yeah, Hamilton has just in the last few years started a addiction medicine inpatient service, which has been very helpful and powerful in beginning to shift attitudes. But I think that stigma is still a big issue for many people.
Okay, so I think we will wrap up. I want to thank all of the speakers, Dr. Fraser, Dr. Brasch, and Dr. Crockford, and the speakers that we've had earlier in the day. And those who have participated in our day, I hope you have found this helpful and will take some of the things that you've learned into practice. I will again encourage you, if you have not already joined CSAM, to consider joining CSAM. And if you're a student, remember that joining is free. And just one last reminder to complete that survey so that you can receive recognition that you've completed this day of training, and also so that we can know how to improve the course for next year. And hopefully next year, maybe it'll be in person. But if not, we're getting more and more practice at giving virtual conferences. So enjoy the rest of your Sunday, and thank you for joining us.